Good afternoon, everyone, and thank you for joining us for today's session, Addressing Ableism in Healthcare. Before we get started, I'd like to offer a brief territory acknowledgement. I acknowledge that as a second-generation settler, I've had the privilege and the opportunity to enjoy the abundance of land and resources of Turtle Island. I recognize the need to build new relationships with the peoples who have cared for these lands since time immemorial, and I am guided by the Dish with One Spoon Treaty that teaches us to live on these lands with respect, nonviolence, and sustainability.
We are honored to present this session on the International Day of Persons with Disabilities, hosted in partnership by the College of Audiologists and Speech-Language Pathologists of Ontario and the College of Midwives of Ontario. My name is Emma Hosine, and I am the Governance Officer at the College of Midwives of Ontario.
And my name is Priya Singh, and I'm the Director of Professional Conduct, General Counsel, and Diversity, Equity, and Inclusion Officer at the College of Audiologists and Speech-Language Pathologists of Ontario. Now, before we get started, there are just a few preliminary housekeeping items. First, if possible, if you can close other running applications to improve connectivity on today's platform. But if you are experiencing technical issues, please log out and log back into today's session. If that does not address your issue, please contact us at dei@caslpo.com and we will try to assist. That contact information has also been posted in the chat feature of today's platform.
This session will be recorded and posted on both CASLPO's and CMO's websites. For CASLPO registrants, you can access the slides via the page Diversity, Equity, and Inclusion eForum series. Viewing today's session can be counted toward your self-assessment tool, SAT, learning goals. And for CMO registrants, you will receive a notice when the recording is available, along with instructions for how to access the recording.
We have saved time for questions, so please enter them into your Q&A feature through your screens on this platform. Questions will be accepted throughout today's presentation, and we will be monitoring all questions and comments. We will, as a result, try to answer as many questions today as possible. And we also remind you that today's presentation is for educational purposes. So in that thought, we want to encourage you to ask questions that are open-minded and provide comments with the same thought process.
And with those items covered, we are very excited to welcome today's speaker, Dr. Hilary Brown, Associate Professor at the University of Toronto in the Department of Health and Society and the Dalla Lana School of Public Health. Welcome, Dr. Brown. Thank you so much for joining us today.
Wonderful. Thank you so much for the introduction and for the opportunity to speak to you today on ableism in healthcare. In my talk today, I'm going to be drawing some examples from work we've been doing in Ontario on disability, pregnancy, and parenting. And so I think this will be very relevant to our colleagues in midwifery who are here, and I'll do my best to also draw parallels to those of you who are coming from CASLPO. So really looking forward to this session. So in terms of some learning objectives for today, our goal is to help you to understand definitions of ableism, including medical ableism. Like I said, we'll discuss how ableism can be experienced in healthcare using examples of parents with disabilities accessing pregnancy and pediatric care. And I'll go over some examples of the role that health professionals can play in making healthcare more equitable and inclusive for people with disabilities, drawing on information for both CASLPO and CMO, as well as some work that we've done with healthcare providers to try to make recommendations for more accessible care. So I just want to pause for a second to let you know that in some of the research examples that I'll be giving today, I'll be discussing very specific examples of negative healthcare encounters that include experiences related to pregnancy loss. So just a heads up about some of those difficult stories. I think they're very illustrative of the types of kind of barriers and difficulties that can be experienced in healthcare. But obviously some of these topics can be difficult and sensitive, so just be aware of that. So I'd like to start off with some context to help us understand disability and ableism in healthcare. So disability is extremely common in Canada and globally. Our latest statistics from Statistics Canada suggest that at least 1/4 of the Canadian population has a disability. And when we talk about disability, there are many different ways of sort of thinking about types of disability, and there's a lot of diversity among the disability community. So disabilities can be conditions that people are born with, so congenital disabilities, or they can be acquired over time due to injury, aging, or the development of a chronic condition. Disabilities can also be episodic, meaning that symptoms can come and go, or they can be more persistent and permanent. They can also be static or progressive, so sort of staying the same in terms of severity over time or becoming worse with time. And importantly, disabilities can be both visible and invisible, and this invisibility piece of disability will become relevant as we go through some examples today. When I'm talking about disability, I'm talking about a number of different types of disabilities. So physical disabilities that impact mobility. Disabilities can also impact vision and hearing, as well as other types of communication. We can also think about cognitive disabilities like intellectual disabilities and traumatic brain injury, and mental health related disabilities as well. So hopefully as we go through some examples today, you can keep this diversity in mind. And again, understanding that people with disabilities have different experiences of barriers in the healthcare system, depending on the ways in which their disability manifests. So another piece of context that I think it's important to understand when we talk about disability and ableism in healthcare is to understand some of the conceptual frameworks or models that have been used over time to understand and define disability. Originally, one of the main forms of understanding disability was using the medical model. So the medical model is a traditional healthcare approach to understanding disability that sees disability as an impairment in a body system or function that is deemed to be pathological. So the goal with the medical model was to treat disability, to rehabilitate disability, and to ensure that individuals are able to experience a return to what would have been called normal function. So this is a model of disability that is very much entrenched in our healthcare system because it was the main way of thinking about disability throughout much of the 20th century. However, this is a model that's been very much criticized because of its conceptualization of disability as something negative to be treated or changed. And so as a response to the medical model of disability, there was a movement towards a social model of disability, which recognizes disability as one aspect of a person's identity among many other characteristics. Disability under the social model is deemed to be a result of a mismatch between the person and the environment. So in other words, it is environmental and attitudinal barriers that create disability by creating spaces and experiences that are not accessible to people with disabilities. And so the social model is widely believed to be a positive change in terms of how we think about disability because it recognizes that efforts to address disability and ableism rest on changing society through changes to policy and care rather than placing the emphasis on changing people with disabilities. So again, recognizing structural and social barriers as opposed to focusing on medical impairments. However, in recent years, there has been some criticism of the social model of disability as well, because of the idea that the social model is incomplete in its conceptualization of disability as something created by environmental barriers. And so one of the newer models of disability relates to disability justice, which sees disability as a social and political issue that is rooted in systems of oppression. So those of you who have heard about issues related to oppression and intersectionality, disability justice really falls into that realm of thinking in terms of understanding that people with disabilities experience human right injustices that are due to discriminatory barriers. And so the way to improve care and experiences for people with disabilities is to address systemic injustices and recognize disability rights. And so when we talk about ableism and negative experiences in the healthcare system, it's really this disability justice model of disability that's most helpful to us in terms of understanding the changes that we need in our system to make care more equitable. So with all of this in mind, so if we think about disability as something that is a result of these systems of oppression and discrimination, that helps us to understand why people with disabilities often experience inequities in social determinants of health. And so, again, I want you to understand this context so that we can understand how ableism appears in healthcare settings, because we know that people with disabilities are entering the healthcare system with these inequities that can impact their ability to navigate the system and to have access to equitable care. And so there is a large body of literature that shows that people with disabilities experience barriers to education and employment. They, on average, have a lower income than individuals without disabilities and are more likely to experience housing instability as well as food insecurity. There's also research showing that individuals with disabilities have less access to good social support networks and are more likely to experience violence. And then, of course, is relevant to our conversation today, even in Canada's universal healthcare system, we know that people with disabilities experience significant barriers accessing healthcare, and we see this at a population level through inequities such as lower rates of cancer screening for preventable cancers. We saw this during the COVID pandemic in terms of people with disabilities having poor access to vaccinations and treatment related to COVID. And so these are all inequities that are very much ingrained in our society and important for understanding ableism. Okay, so moving along here, what is ableism? So I've included a definition here that I think is helpful for grounding our conversation. Ableism can be defined as the discrimination of and social prejudice against people with disabilities based on the belief that typical abilities or people without disabilities are in some way superior. And the quote goes on to say that at its heart, ableism is rooted in the assumption that disabled people require fixing and defines people by their disability. So you can kind of see how the medical model of disability kind of permeates through this issue of ableism. And then finally, like racism and sexism, ableism classifies entire groups of people as less than and includes harmful stereotypes, misconceptions, and generalizations of people with disabilities. So this is kind of a, a theoretical way of thinking about ableism, but let's go into some concrete examples. How does ableism show up? And when people think about ableism, it's easy to think about very stark examples. So many of these are things that we've seen in the 20th century. So segregation of people with disabilities in large-scale institutions, the eugenics movement of the mid-19th century. And I'll just pause on those 2 points to say that, those are historical events that continue to have a major impact on the experiences of people with disabilities today. Eugenic notions were extremely common in the 1900s, and sorry, that should say 20th century, 1900s. So from the 1920s to the 1970s, people with disabilities experienced involuntary sterilization at very high rates, with the idea that medical professionals felt that they needed to prevent the transmission of disability through what they deemed to be negative genetic traits or characteristics. And so they attempted to restrict childbearing among people with disabilities using this approach. Likewise, up until the 1970s, large-scale institutionalization of people with disabilities was extremely common. Now, what a lot of people don't realize is that in Ontario, the last large-scale institution for people with intellectual disabilities didn't actually close until 2009. And so although the process of deinstitutionalization really became prominent in the 1970s and 1980s, it took a really long time. And we're talking about within the last 20 years, there were still institutions for people with intellectual disabilities in our province. So again, these are very obvious examples of ableism and ableist practices within our history. More recently, I think we see ableism in specific ways like lack of compliance with disability rights laws. So in Ontario, that would be AODA, or Accessibility for Ontarians with Disabilities Act. We can also see ableism in terms of failure to incorporate accessibility into building plans. So not having accessible ramps going into stores and office buildings, for example. And then of course, other obvious examples would be open mocking of people with disabilities. So again, I think when people think about ableism, these are perhaps some of the examples that come to mind that may seem quite obvious. But what I really want to emphasize for you today is that ableism can also show up in more insidious or subtle ways that I think are really critical for understanding how this can impact healthcare experiences. So ableism can show up in terms of talking to people with a disability like they're a child, so using patronizing tone, speaking for or about them in front of them rather than enabling them or allowing them to speak for themselves. Ableism can also appear in terms of people framing disability as something that's either tragic or, on the other hand, inspirational. So that can also be something that people with disabilities find to be ableist as well. Often people with disabilities find that people will ask them invasive questions about their personal medical history. So how did you get that injury, for example, or their personal life? So those invasive questions are great examples of ableism. Using someone's mobility device as a handrest or footrest, or perhaps putting a bag on something for somebody's mobility device that's in use. Assuming disabilities are visible is also a form of subtle ableism. So assuming just because you can't observe a disability that it isn't present. Choosing inaccessible venues for meetings or events, or things like not providing sign language interpretation, closed captioning, and other forms of communication accessibility. These are all examples of ableism as well. So what about medical ableism? Medical ableism basically describes these same sorts of issues, but in settings where we're thinking about practices, policies, and attitudes about healthcare. And I think more specific examples related to medical ableism that occur are issues around underestimating the quality of life of people with disability, denying access to healthcare for people with disabilities. Another example from COVID was triage protocols that place less emphasis on life-saving procedures for people with disabilities if they came to the hospital with COVID, so that would be an example of denying care. Making assumptions about individuals' needs because of their disability, and then again, failing to provide accommodations in healthcare contexts. So again, these are all ways that medical ableism can show up within our healthcare system. I want to also emphasize that medical ableism is also a systemic and structural issue. It's not just an issue of relationships between healthcare providers and patients, or interactions between healthcare providers and patients. It's also really embedded in the way that our healthcare system is set up. So a lack of accessible healthcare equipment and spaces within hospitals and physicians' offices, lack of funding to accommodate accessible care when people require accommodations. And I think one striking example of medical ableism that I find to be particularly important, and which is one of the reasons why webinars like this are so critical, is a lack of healthcare provider training about disability and lack of prioritization of disability education in health professional development is a really important and serious issue related to medical ableism as well. And then finally, lack of policies to govern accessibility in healthcare. And for this one, I just want to pause for a moment again to reflect on the fact that in Ontario, AODA is our major policy, which is meant to govern accessibility in public spaces. However, it does not actually govern healthcare spaces. Several years ago, a healthcare standards committee was brought together to create healthcare standards for AODA. Those have been drafted. They're available online. So if you're interested, you can Google AODA healthcare standards and you will see the draft recommendations. However, the Ontario government still has not put these into law, and that's a major issue that is widely criticized by the disability community and disability advocates, and again is a really important example of systemic and structural medical ableism. I also want to make a note here about the importance of intersectionality. So it's really important when we're talking about disability to recognize that it's one of many forms of oppression that people can experience. And people with disabilities also have intersecting social identities that impact their experiences and care, whether that be related to their gender, their sexuality, their nationality, or their racial identity. Of course, this list of identities is not exhaustive, but I do want to really emphasize the importance of understanding the discrimination of people with disabilities in the context of the other forms of oppression that they can experience. And again, we'll get into some of that as we go through some examples. Okay, so to give you kind of a more concrete understanding of ableism and healthcare, I want to draw on some examples from my own research at the University of Toronto. I'm a public health researcher that does work on disability and reproductive health, and a large component of my research program is focused on disability, pregnancy, and parenting. And I think this is a really important example of how people can experience medical ableism because of the unique ways in which pregnant individuals interact with the healthcare system. And so I'm going to give you some examples as I go through this, and we'll try to draw it back to health professions more broadly as well. So why disability, pregnancy, and parenting? Again, this is such a critical area because of the focus of the eugenics movement. So our very important history of ableism and eugenics in Canada and globally was very much focused on preventing childbearing in people with disabilities via involuntary sterilization. And so understanding disability, pregnancy, and parenting today is kind of one of the really critical points at which people with disabilities still experience ableism and what I would call microeugenics in terms of the negative reactions and pressures that they experience from healthcare providers in pregnancy. The 2006 United Nations Convention on the Rights of Persons with Disabilities was very explicit in terms of protecting the reproductive and parenting rights of this population, including their rights to retain their fertility, marry and found a family, and access good quality reproductive health care. And yet, as you'll see from this research, pregnancy and parenting in people with disabilities is an area that continues to be characterized by neglect and prejudice, as well as disapproval and misunderstanding. So I think, again, a really poignant example of how medical ableism can show up. So again, just to put this into context, one of the reasons why we do research on disability and pregnancy, as well as the early parenting experiences of people with disabilities, is because we do see health disparities in this population at this critical juncture in their life course. So our research and others suggest that even in Ontario, people with disabilities are able to access routine prenatal care later in pregnancy and receive fewer than the recommended number of prenatal care visits, which suggests that there are barriers to connecting with and accessing prenatal care providers. We see higher rates of complication, including maternal and newborn morbidity and mortality. So there's a real reason why we want to be able to provide better and more accessible care. We also see disparities in other outcomes like reduced access to breastfeeding initiation and support, as well as reduced access to routine child preventive health care and immunizations among infants of individuals with disabilities. So again, some preventable disparities that can be addressed through more accessible and more equitable health care. So over the last 10 years or so, we've been doing research on this topic. It's a collaboration between our academic research teams at the University of Toronto and an advisory committee that includes representatives from all the little logos that are at the bottom of the screen. I won't go through all of them, but we have a number of really important disability advocacy partners, as well as representatives from the Ontario Ministry of Health and the Ministry of Children, Community and Social Services, along with some critical clinical groups, including the Provincial Council for Maternal and Child Health. And we work directly with people with lived experience on our advisory and as part of our research team. Again, I won't get into too many details about the research itself, but just to give you a little bit of context, the work that we've done uses health administrative data on about 150,000 births to individuals with disabilities, as well as 1.4 million births to people without disabilities in Ontario over a 10-year period. And we've conducted a series of in-depth qualitative interviews with over 60 people with disabilities with a birth in the last 10 years, as well as service providers and decision makers in Ontario. So I'm going to go through some examples of the types of experiences that we see that are critical examples of medical ableism. And they kind of fall into themes of stigmatizing attitudes, making assumptions about needs, failing to provide accommodations, physical accessibility barriers, insufficient provider knowledge, and a lack of funding and policy support. And again, although these are specific to pregnancy and the early parenting period, I think they are translatable to other healthcare settings because of the ways in which they demonstrate medical ableism. So let's jump into some examples. So stigmatizing attitudes are some of the most common issue that we see when we talk to people with disabilities about their healthcare experiences. This is a quote from somebody who uses a mobility device about her first prenatal care appointment with her obstetrician. And she said, I met him, or the obstetrician, for the first time when I went in to confirm the pregnancy. And he was like, what brings you here? She said, oh, I just found out that I'm pregnant. And he looked down at my wheelchair and he looked at me and he said, are you here to get an abortion? She said, I was absolutely stunned. No, we've been trying for a year for this pregnancy and we're really excited. And she said that was a really weird and terrible experience. So again, really clear example of medical ableism and eugenic notions around the idea that people with disabilities shouldn't be or wouldn't be having pregnancies. Here's an example from a parent accessing pediatric healthcare for her young son. She talked about living in a rural area and how she felt protected and supported, given that she knew a lot of the providers where she lived. But she said, if I ever traveled or I was in a bigger city, I would definitely not take my children to a healthcare provider without able-bodied accompaniment. It's just because of stigma. For example, my son had his foot cut open and he required stitches and he was bleeding. And I refused to go to the emergency department because I was like, my child is injured. I know it's dangerous. So I made my husband take time off work and go because I felt threatened. So again, another example of how stigmatizing attitudes can come up in healthcare settings for people with disabilities. We also often hear that people with disabilities experience providers who make assumptions about their needs and kind of assume they know more about the person's disability than the person does themselves. So this was somebody who was in the hospital leading up to a delivery. And she said, I had to keep explaining to the medical staff every rotation what it was I had in terms of the disability and why I was there at the hospital during pregnancy. A lot of people thought I might not be able to feel contractions because I'm paralyzed. And I said, look, no, that's not what I have. And some of them would even argue with me, no, you're paralyzed. And she said, no, I can still feel my legs. And she said, I think either because of my disability or not, they just seem to not always be certain that they could take my word for things. Here's a quote from a provider that shows the assumptions that providers sometimes make about the needs of their clients or patients with disabilities. And this was in the context of pediatric care. The provider said 9 times out of 10, if parents disclose a disability, they usually get the support they're looking for in terms of access and accommodations, but most of the time it would not be offered outright. most of these offices aren't going to necessarily take the time to inquire whether somebody would need assistance. The assumption is that people coming in are able to fill out forms and understand them. Why would there be an issue? Providers don't even question it. So again, making assumptions that people don't have specific needs that could be addressed. We also see lots of examples of failure to provide accommodations, and this happens especially for people with communication-related disabilities, including deafness and hearing loss. This was somebody who experienced a miscarriage and received the information in a really traumatic way because the healthcare provider failed to find an interpreter, a sign language interpreter. So she said, I could see my husband was crying, but there was no interpreter around. And the nurse came back. She said something to my husband and he was listening, and my husband was just in total shock, and he signed to the individual dead. And it didn't hit me right away because I had the other twin with me. So this is somebody who had twins. One of them passed away. She said, I was happy. I was looking at the other one that was in my arms, but then he signed dead. And so again, this is an example of, had there been better access to care, this information could have been delivered in a less traumatic and troubling way. Here's an example of someone accessing a physiotherapy appointment for their child. Again, this was a deaf individual. She said, we went to a physiotherapy appointment because of my son's elbow. We went, no sign language interpreter. The therapist was speaking with the children, chatting at length. Nobody shared with me what the conversation was about. Not one iota, not one single word. It was great that the therapist was engaging with the boys. Again, it's my right as a mom to know what's going on. I'm seated there and I feel like a fool essentially. I have to make the choice to let that go and not be bitter and angry. I just try to think that I haven't missed out on anything. And I'll emphasize again here that it is a human right for people who are deaf or hard of hearing to have access to sign language interpretation, and it is a healthcare provider's responsibility to arrange for that. In addition to these examples, we've heard lots of examples of people with disabilities who, where providers have asked the children to act as sign language interpreters for their parents, including around really complex information around medication and treatment plans. And it's just a really inappropriate situation and an example, again, of how important it is to have healthcare that's accessible to everyone. So that's in terms of communication barriers. We also see this in terms of physical accessibility barriers. Again, particularly in pregnancy-related healthcare settings, but also healthcare settings more broadly. This was an individual who, again, used a mobility device, and she talked about how the obstetrician's office was not equipped. They were not accessible by any means. So the only way I was weighed was because my husband picked me up and we'd be weighed together, and then he'd be weighed and he'd put me on the exam table. So they subtract the husband's weight from their combined weight. Again, a really infantilizing experience that could have been avoided through more accessible healthcare approaches. In the context of pediatric care, another example, the interviewer asked, do your children's doctors ask about your access needs before appointments? The participant said never. She said sometimes they'll move a chair for her mobility device once I'm there. I think it's kind of not really addressed. So again, lots of examples of how accessibility needs are not being met. And then finally, from a provider's perspective, this was an obstetrician who talked about how they didn't have wired lifts or any of the sophisticated things you'd see at tertiary care hospitals. She said, at my hospital, really no support. It's just I'm given the clinic space. So infrastructural barriers to physical accessibility. As I mentioned, insufficient healthcare provider knowledge is a really critical example of how we see ableism appear in healthcare settings. We've heard parents talk about how, when they've never been confronted with a patient or client who has a disability, ignorance is sort of their barrier. It's not something they intend, but I often will have to lead them to a solution. If I don't come prepared with a solution, that's where I find there's a disparity. Likewise, from a provider perspective, this provider said, I don't know how to navigate conversations about the needs of parents with disabilities. If it's a visible disability or a parent shares it, then we try to accommodate, but I certainly don't think we ask up front about parents' needs and how that might help facilitate their child's needs being met. So again, kind of assumptions about visible versus invisible disabilities. And then finally, this was an obstetrician who said, in medicine, disability was an area that I sort of felt we got no exposure to at all, and it wasn't really discussed or anything that people had training in. And then one last example in terms of more infrastructural issues, in terms of the lack of funding or policy support for accessible care. This was a physician who talked about there's a pie, it's this big, and you don't suddenly get extra time. So if you're spending more time with a patient with a disability, it means less time you're spending on other things. I hate to say it's a barrier, but you don't get paid for the time. And likewise, it's very contingent on people understanding the value of what we do. If you're measuring success by how many patients you see in a half-day clinic, we're not achieving accessibility at all. Certain needs are valued differently. Like if it's a formula, it won't be approved at all, which doesn't think about families as a whole. Okay, so again, some specific examples related to pregnancy and parenting, but I hope you can see how those same types of barriers may occur for other types of clients or patients or other healthcare settings. And I want to kind of draw it back to health professions as a whole to talk about some recommendations for how we can give more accessible care. So I've sort of divided these medications into a number of areas. We can talk about the need to address healthcare system structures and processes. We can talk about service provider knowledge and resources, as well as more accessible patient supports. And I won't get into the scientific side of things, but I think all of this work really does show the need for better data to understand people's experiences and to make improvements to care. And with all of these recommendations, I'll emphasize how everything that we do to improve healthcare has to include people with disabilities in the process to make decisions and improve access. So in terms of modifying healthcare system structures and processes, it's critical that healthcare spaces, resources, and related technology devices are accessible. I know that different people in these calls are under different remuneration policies, but another critical piece to understand is that we need flexible approaches to how we remunerate providers for their time so that there can be longer appointments when needed, more flexible appointment modalities such as virtual care or home visits. And of course, we need to embed disability affirmation within all of this so that healthcare structures and processes are set up with a positive perspective in terms of affirming people with disabilities. Healthcare provider knowledge and training is critical, and I'm so glad for webinars like this one that hopefully help to improve awareness. But I do think that all health and social service providers should receive formal education and training about disability and accessibility related needs in their original, undergraduate and professional training. And this training really needs to see disability not as a medical outcome to be screened for or treated or rehabilitated, but rather understand disability as an equity-seeking population and address ableism and delivery of respectful care. There's also a need for clinical practice guidelines and other resources that providers can use to support their delivery of more equitable care. And like I mentioned, it's important to emphasize that people with disabilities should be actively involved in this training and development of resources. On the patient care side of things, hopefully you saw from the examples that I gave of the many ways in which healthcare itself and the delivery of care, the interactions with providers are not accessible. So we need to make sure that all patient-facing resources and programs are accessible and evidence-based. And I think there's a real value for healthcare providers to work with disability community organizations to improve the accessibility of resources. So I want to end off by talking about some practical tips about how these recommendations can be put into place. And here I'll draw specifically on some of the resources that many of you will already be aware of through your respective organizations, and then I'll draw it back to more specific tips related to disability. But some of you with CASLPO may be aware of your guide for equitable and inclusive services. It really emphasizes the idea that every individual is unique, and so it's critical to practice with cultural humility, which means addressing and recognizing biases that can be either conscious or unconscious. And in the context of this work, this means engaging in anti-discriminatory practices, which includes anti-racist and anti-ableist practices as well. So I think the emphasis in these resources or this guide on cultural competence and person-centeredness of care is really critical, and we'll see how that plays out in some of the practical tips that I'll provide in just a moment. Likewise, for those of you who are joining from CMO, you also have professional standards that go into the importance of person-centered care. So this piece really discusses the importance of focusing on the client in their life context, recognizing the central role that a client has in their own healthcare and responding to their unique needs. And if you think back to some of the examples I gave from our research and the ways in which providers made assumptions about clients' needs, I think the second point about recognizing the role that the client has in terms of autonomy in their care is really critical. Likewise, person-centered care involves working with individuals in partnership and offering high-quality care that's provided with compassion, respect, and trust. So how can these notions of person-centeredness and cultural appropriateness that you've seen in your own organization's guides be integrated in healthcare services for people with disabilities? So we worked with our advisory committee and with some clinicians to come up with some practical tips for a more accessible delivery of care. These are adapted from a resource that we have available through a public health nursing organization, and I'll show you how to access that resource at the end. But the tips that we came up with are very simple. So do the research, take time to learn about your client's disability and including their accessibility related needs. And this can often be as simple as just asking. So ask people with disabilities what works for them. So for example, related to communication needs or physical accessibility, and what or who they need to have in place to feel informed and supported. And this really comes from a place of understanding that people with disabilities are experts in their disability and their needs in healthcare settings. It's really critical to be proactive. I think you probably saw in some of the quotes that I provided that often providers are not asking about accessibility needs up front. And so this means that instead they're responding to barriers and crises as they arise. So being proactive means starting planning resources and supports early before appointments so that you're creating an accessible and supportive environment rather than reacting to issues as they arise. Our group has also talked about the importance of meeting people where they are. So this might be more relevant to the midwives in the group, but we often hear from people with disabilities about how useful it is for them to have home visits because they're able to eliminate many accessibility barriers just by receiving healthcare visits in their home. Communication is critical, so talking directly with people with disabilities rather than for or about them, and making sure that any other providers that are involved in their care are also informed about their preferences and needs. We heard a lot from the people that we interviewed about the need to be creative within our inaccessible system, so considering what adaptations are needed to meet physical, sensory, communication, and learning needs. So this includes not only thinking about accessible spaces, but also the other supports people might need for full communication accessibility, whether that be sign language interpreters, text-to-speech, or visual aids. And then I think it's also important to think outside the box. So you're probably very used to collaborating with other healthcare providers. But there are also many incredible disability advocacy organizations and services that are out there that can help to make sure that resources related to disability and other life circumstances like poverty or transportation barriers are put into place. And this really means that it takes a team to provide accessible care. So ask people with disabilities what care they're receiving from other providers. Often we hear from people that they're sort of acting as the connection point between many different providers related to disability specialists and other healthcare providers. So coming up with ways to connect providers directly with each other, for example, through notes and other forms of communication can be extremely helpful. And then taking the time, so providing more frequent or longer visits or sessions can sometimes help to address accessibility related needs and to be more supportive of addressing the other tips that we provided in this list. So here are some resources that we have available. This is the one that the tips that I just mentioned are described in more detail in this resource. It's available through the Public Health Nursing Practice program through McMaster University. So if you Google it, it's available. I can also provide a link to be distributed. Likewise, we have a resource that we created for the Provincial Council for Maternal and Child Health. It includes a resource for parents, for healthcare providers, and for administrators. It includes a lot of data about disability and pregnancy and recommendations for improved care. And then if you're interested in the research that I've described today, our full report is available. Again, I can provide this link. The name of the report is Equity and Inclusion in Pregnancy Care, report on the pregnancy outcomes and healthcare experiences of people with disabilities in Ontario. And I'll just say again, for those of you joining from CASLPO, even though this is very much focused on pregnancy, I think you'll find that many of the barriers that people experience in healthcare settings related to pregnancy are very much translatable to other healthcare settings. So this may be useful to you as well. And with that, I will end there, and I think we have some time for questions. Thank you.
Thank you, Dr. Brown. That was fantastic. I do have some questions, so bear with me because I'm scrambling through screens here. Okay, so one of the questions is around providers with invisible disabilities, such as hearing loss. And the note is that it can be challenging to feel truly accepted by colleagues and within our system. So the question is, what strategies or changes, both personal and organizational, can help providers feel truly supported, connected, and free from stigma in their professional communities?
That's a great point. So I think if I understand the question correctly, we're talking about providers themselves having disabilities that may not be visible. Yeah, I mean, I think ultimately it's a structural issue. And so it comes from organizations having workplace policies and environments that are supportive of people with disabilities. And I think organizations are doing a lot more work to ensure that's in place, but obviously it's not perfect and a lot more can be done. I do think that within that work, there really needs to be a recognition and training for all employees that not all disabilities are visible. So you gave hearing loss as an example. There's other, autism, ADHD, mental health disabilities. There are many, many disabilities, chronic pain. There are many disabilities that are not visible. And so I think just a better understanding of what is disability and how can different people experience it is really important, and that comes with advocacy and it comes with time. I don't think there's a simple solution, but it is, I think, an organizational responsibility to provide the training and policies to make work more accessible and welcoming.
Yeah, and I think that based on what you're saying and this discussion today, perhaps a little bit of redefining what disability is and what that, for want of a better term, manifests as, because I think we have some very traditional understandings, and so breaking that down is a key part of this. Another question is, what role does language we use play in reinforcing and challenging ableist attitudes?
Thank you for raising that. I was actually thinking as I was going to the presentation, I wish I had a slide on person first versus identity first language. So I'll put that in here. So there's a lot of variation in the disability community about what language they prefer to describe disability, and it falls broadly into two categories. So person first language, that would be something like, you know, a person with Down syndrome, a person with a disability. It was language that was originally promoted to try to emphasize a person's humanity before their diagnosis. It was really a response to eugenics and institutionalization that dehumanized people. And some disability communities, particularly communities with intellectual disabilities, still prefer that language on average. Identity first language, so that would be examples like disabled person or autistic person, deaf person. This is a form of describing disability that reclaims disability identity as something to be proud of, and embracing the broader disability community. It's part of disability justice and social justice, kind of pushing back against the medicalization of disability. And some populations prefer identity first language. I think from a clinical perspective, it's really important with your clients or patients to pay attention to the language that they use to describe themselves and not make assumptions. There may be scenarios in which it's appropriate to ask people what language they prefer. Certainly there are kind of trends. So for example, autistic individuals often prefer identity first language, and that's well documented, but it's not true for everyone. So understanding that there are these sort of two broad ways that people can prefer. There's also cultural conceptualization. So deaf communities often don't even identify as disabled. And so just being aware of those differences and asking when appropriate what people prefer, I think is really important.
That's perfect. Thank you. I want to go back to a point that you made a little bit earlier in the presentation. I just want to drill down a little bit more, and it was really in relation to asking patients, what can be provided. Do you have any specific examples or suggestions on how to approach the conversation? Because I think some of us may not feel as comfortable broaching that conversation and starting that. So any suggestions or tips?
Yeah, that's a great question. And I think one of the reasons why it can be uncomfortable is we often don't know when or how we should ask, but I would say asking about accessibility needs should be a routine part of setting up any healthcare appointment. And then everyone's asked, regardless of your knowledge about their disability status, regardless of if they even have a disability. And so what we often hear being recommended now is that in any of your intake forms or whatever assessments you're using when you take on new clients or patients, there should be some sort of general question about, do you have any accessibility related needs? It's a very broad and non-threatening question, and that gives people the opportunity to disclose that they have a disability if they wish, and to arrange any accommodations that they require. And what I would say is that it's really important that those sorts of accessibility questions be routinely asked and documented in consistent ways, because we often hear from the people we talk to that they have to explain their disability and their accessibility needs over and over and over, and that can become quite burdensome. But if it's recorded somewhere in an appropriate way, and then it's just dealt with from all the providers that are providing care in terms of knowing their accessibility needs, that can reduce some burden for people as well.
I think that that's probably consistent with a lot of advice that we've heard from other providers other speakers in terms of how to broach conversations, is to ask it open-ended and leave it broad. Emma, I'm going to turn over to you.
Yes, thank you so much. Dr. Brown, we have a few questions around genetic testing. So just for the sake of time, I'll maybe just pose one that's a little bit more high level. How do providers both discuss and deal with genetic screening in the context of the discussions we're having today around ableism and eugenics?
Yeah, that's a really important question. And I think what we've heard from the folks that we've talked to who have experienced disability in pregnancy is they do want information, but it's important that those conversations be approached with sensitivity and without making assumptions. And I think the same thing goes for medications that people might be taking that might carry risks during pregnancy. People will decide what their tolerance is to making different decisions about their care and how they want to proceed with pregnancy. So just having information available to people, approaching conversations with care and support and empathy and sensitivity. I think, we could do a whole webinar on that question, but I think that would be my sort of 2-second advice. Yeah.
Thank you. Thanks.
I'm cognizant of timing. Emma, I don't know if you have any more questions on your end.
No, that's the only one that I was seeing coming through.
Okay, excellent. So I want to be respectful of everyone's lunch hour potentially. So I want to say thank you so much, Dr. Brown, for such a powerful and insightful conversation. I think we've all learned something pretty important today, even if we were aware of the concept. A lot of those stories were very powerful, and sharing those experiences, I think, really emulate and emphasize what those patients are feeling. So we really appreciate the information that was shared with us this afternoon. I just want to take the quick opportunity to just offer my sincere thanks to the audiologists and speech language pathologists on the call. Your commitment in delivering compassionate care and your willingness to learn and adapt to Ontario's diverse population has encouraged my work, and I think our collaboration with Midwives as well. So I extend that thank you to our midwives on the call today.
Yes, thank you to everyone who has joined us for this really important and impactful conversation. And as we mentioned earlier, today's session has been recorded and will be available both on the CASLPO website and the CMO's website. So we would encourage everyone to share this webinar with colleagues and to encourage those they work with to also view it and to think about some of the recommendations and the practical tips that have been shared today and how we can all implement them in our practices and our practice environments. So thank you so much for joining us today. Hope everyone has a wonderful afternoon. Thanks one more time to you, Dr. Brown, and wishing everyone a wonderful rest of their week.